Hello and welcome to another edition of Backstage. It's a pretty special one because we're going to be talking all things COVID-19. Now, what's happening back here in Australia? We're getting a lot of information, and some of this information is correct. Some of it's very hard to digest. I got something in my inbox the other day, and it pretty much said if you drink hot water, wash your hands and steer clear from your neighbour, you'll probably knock this COVID on the head. So I thought with all this sort of stuff floating around, it's better off to speak to people a lot smarter than myself. So I've been able to get hold of some doctors all over the planet, and as I said, men a lot smarter than myself. Now, introducing the guests in no particular order. The first is Dr. Chris Mobbs. Now, he's a senior staff specialist at the University Hospital Geelong Emergency Department, and that's the A&E if you're in the UK. He also works for Racing Victoria as the industry doctor at race meets all around the state of Victoria. He's the frontman for a Foo Fighter cover band, and he has his own podcast called Inside the Helisphere. So if you're Molly Meldrum, as he says, do yourself a favour and check it out. My second guest is Dr. MATTEO BELTEMACCHI. Did I pronounce that correctly? I hope so.
Yeah.
He's a sports medicine specialist based in Varese, and now this is only 30 k's from Milan, so one of the epicenters for this pandemic. His three main jobs are team doctor for the Mitchelton Scott Pro cycling team, the medical director of a sports clinic in Varese, and a full-time dad, particularly during the last 30 days because he's been in forced lockdown. I worked with Matteo in my final year at Green Edge, and we trained him up on how to speak Australian, so I'm looking forward to his insights. And last but not least is William Wallace. Sorry, it's James Shepherd. He's coming in strong from Scotland. He's a specialist in infectious diseases and currently a clinical research fellow at the MRC Centre for Virus Research in Glasgow. As I said, very smart guys on the show today. His hobbies usually involve rugby and going to the pub, both of which have been viciously stolen from him by COVID-19. And he's spending most of his time with his wife and two young daughters. Now, if it's any consolation, Shep, I had tickets to go see Backstreet Boys in May, and it's looking very doubtful, mate. And apologies have come through from your wife regarding your hair, as lockdowns come at the worst possible time in your haircut cycle. Now, fellas, I want to kick things off with you, Matteo. You're living in, as I said, one of the epicenters of this pandemic. What is life like there at the moment, mate?
Well, I actually have to say that there is a double perception of life. The first perception is the one that you live at home in a completely locked down. So the one inside the affection of the family, you feel protected, you feel you have no worries, you just focus on the needs of your children, if any. You go on day by day with life, normal life, waiting the authority tell you you are free to go out, also to let your dog do the pee-pee. And yeah, the second is that is the second life that the television, the journalists tell you. So just the number of infection, the death, the health system, how it's going, the economy, and the life in Italy is the north of Italy is very bad.
The images, mate, that we're seeing here in Australia have been devastating and really shocking. Chris, I'll ask you, mate, how's the industry in Australia been taking a lot of these images that we've been seeing coming out from Italy?
Yeah, I think when we set this up, Dan, I had to say to you that I'm glad Matteo said what he said, because there's very much, I think there's two things going on. There's the subjective experience of all of us, and we have a choice of how much of that media we take in, and my personal choice has been I've been focused on the medical side of things, which we'll come to, I suppose, our preparation, and we're at a totally different phase from Italy, obviously. But then, as far as your intake of the media and the images and the figures and that sort of thing, I think people have got to be really careful about this. it's unheralded. Unless you go back 100 years, none of us have been through anything like this as a planet. And I'm just really concerned, apart from, there's so many unknowns. We don't know how bad it's going to get. There's lots of different estimations, but and I'm sure James will know more about this than I do. But that the amount of these images that we're taking in through whatever media, social media or television, I think has to be, you've got to be really careful with that. And I've personally chosen, I'm not on any social media. I haven't been for 6 years or 7 years, and we don't have television in the house. I've just avoided news to protect my family, to protect my young children's well-being. I'm not burying my head in the sand because I'm completely immersed in it at work, in all types of work. But the sense I get from my interactions with people, when people come to me at horse races or in the hospital and say, look, really, what's going on? How bad is this? And my sense is that everybody's just working themselves up into this terrible state, which can't help you at all. So I don't know if I really answered your question there, but I just wanted to be really strong with that message that we're just saturated with news 24/7. We have been for 30 years. The internet's happened and social media's happened, and this has come along on top of all of that. And I know we're going to get to the isolated people, the people with mental health issues, and people that don't have those issues. I think no matter how robust you are, if you're continually given distressing messages from the media, and that's all there is apparently at the moment, there's no other news in the world, then even the hardiest of people are going to struggle, I think.
Yeah, I think you make a good point, because I'm often reminded by my wife Sarah, who's a doctor, that I'm not medical. So when you don't really know what's going on, you do reach out to all these messages that are coming our way. James, I want to ask you, mate, can you just give us a bit of background on your current position on all of this, and what your thoughts are from what you've heard from Matteo and Chris?
Yeah, so I'm an infectious diseases specialist, and I've taken some time out of that at the moment to do some research into viral diseases. So I've been doing that for like the last 2 years, and kind of interestingly, this is the kind of thing I'm researching. So like emerging viruses and how we detect them and how we diagnose them, and most of my work on that's been done in Africa. But obviously, this has come along. I mean, if it wasn't so awful, it would be. It's very interesting to me because it's kind of what I've been researching. So I've kind of paused the research I was doing on the stuff in Africa, and I've kind of moved my research over to responding to COVID-19 from a research point of view. So we can maybe talk about that later. But just going back to what Chris said about the information. So I would agree with him. It's going to be very difficult to manage that, given that there is nothing else on the news. So like over here, anything that would have distracted people, like sport or whatever, has been cancelled, and so people are kind of relentlessly getting this information off of the news, and I mean, I think I can handle. I have things to do at home. I have a family. I'm still working, which really helps. So I'm still obviously engaged in doing something that keeps me busy. But for people that don't have work and are just stuck at home, and maybe people who don't have family or are alone, I think the constant, and all they've got to watch is this news, is that's going to cause trouble going forward.
Yeah.
Do you think that the reactions from governments globally have been justified, or do you think that there's been a little bit of hysteria as well?
I think, I mean, nobody's seen this virus before, right? So we've only known this thing existed for 3 months. It's only been in the human population for 3 months. So, and initially there was a lot of, we weren't really sure about, how infectious it was, how pathogenic it is once it gets into people. So various governments have taken, different steps and treated it differently. So I think it's very difficult to say you should have done this, you should have done that, given that there was very little information initially. What I would say is that I think it's becoming apparent that governments that acted quickly and took kind of more extreme measures quickly are seeming to be getting on top of it a bit better. So places like South Korea, Singapore, Hong Kong, they kind of came in very hard with social distancing, with quarantine, with testing very quickly, and they seem to be seeing a lower number of cases and a less severe outbreak on the back of that. So I would going forward, I think we need to maybe need to look at more severe restrictions like a lot of places have in place now.
Obviously, going back to what I'm ingesting from the media, obviously there's a lot of talk on what's happening in the UK. What's the current situation with the NHS over there, and have you been talking to many of your colleagues in the industry as well, and how are they going?
Yeah, so I'm kind of involved in it from the NHS up here in Scotland, and we haven't really seen that many. I think we have about 1,000 cases in the country. I think in my area, we have about 250 people in hospital, and of them, not all of them are requiring intensive care. So we're kind of handling it at the moment, but I'm not sure how it's going to pan out in the next few weeks. I think down south in London, they've got a lot more cases, and I think they're struggling a lot more there with intensive care capacity. And also a lot of staff are off sick. A lot of staff seem to have got it. And a lot of staff are self-isolating because they have symptoms. So I think down south it's a bit more of a struggle.
Yeah. Matteo, why do you think this virus spread so fast in Italy?
In Italy, they always say that they completely agree with the WHO, the recommendation. I think that's sometimes
they should have been a bit more severe early.
More severe and in time. I think that the perception here is that the coronavirus, is always 5 to 10 days more in front of us. By our choice, the Italian choice, we were the first that spread such a dramatic news about the contagions. Other countries, in particular French and UK, I hope no one gonna hate me, but maybe shut up sometimes, or shut up before. For example, in Italy, we say that the world know that the mortality rate is close to be 10%. Is not real.
If you look at somewhere like Germany, who have tested thousands and thousands and thousands of people, the mortality rate in Germany is much smaller, and that's just because they've tested more people. Yeah, so they know that there's a lot of people who have very mild symptoms, whereas in the UK and maybe in Italy as well, certainly in the United States, the testing capacity is much lower. And we're only testing the very sick people, so that gives a very skewed. The numbers appear skewed. And just touching back on your point about the health, it's not just COVID. If your ICU is full of patients with COVID, then you can't do big cancer operations. If someone comes in with a myocardial infarction or has a cardiac arrest and they need to go to the ICU, that person isn't going to do as well. So it kind of, if everything's clogged up, it impacts on very common things that you might be able to manage much better, but the management of that's going to be impaired now because, as you said, the system's clogged up with patients with COVID.
Chris, what we're seeing globally as well, when Matteo's talking about hospitals collapsing and healthcare systems collapsing, they're having to call on a lot more support from people that were retired. I think they're talking about in Australia, they're going to fast track people that haven't quite finished their university qualifications to get them in if possible. What are those sort of things that you're sort of preparing for back in Geelong?
Well, there's where to start. The thing is that with all of this, there's been an enormous amount of corridor conversations going on, so I've heard all of that, and we've spoken to students and we've spoken to the local medical schools, and all I can say is at the moment there's no plans to be using students right now today as interns, as doctors, fast tracking them through, but that could all be different next week. But what's happening is that well, in Australia, we're in such a period of uncertainty. This is exactly like the calm before a cyclone. Everybody's raiding the supermarkets to buy tin stuff. I've never worked 3 such quiet shifts in the ED as I did the last 3 shifts I worked. There were beds everywhere. We're practicing all of our processes for donning and doffing personal protective equipment. What do we do if this happens? What do we do if that happens? It's all that. If you've got a situation where everything begins with a what or a why or when, you can't say there are no answers. I mean, we in emergency medicine, which is my specialty, we deal with uncertainty all the time. I mean, it's just how we exist. It's, you know, it's abdominal pain. It could be this or this or this or this, and we get used to living with uncertainty. So that's kind of we're kind of in that situation, ramped up to an enormous degree. I think the problem people are having is that everyone's looking for answers, and I've heard blame stuff as well. It started off with whatever that person in charge of America said, you know, about Chinese people, and then it's, oh, the old people are going to get it, the young people are fine, and actually that's not true. Healthcare workers are fine as long as we use personal. No, actually, there's just so much uncertainty, and when people are forced to live in uncertainty for an extended period of time, that's when you see reality start to bite. And I think that's where we're getting to now. When people go out, and at first it's like, oh, you know, we're all going to be locked down. There's all these funny memes being thrown about. But now it's actually starting to bite a little bit. And people, you know, humans by nature of, I'm just going to get a little bit philosophical for a second, apologies. We live in a constant state of denial. We have to, because we're aware of our own mortality. We know it's coming, but it's there. It's somewhere in our future. All of a sudden, as a global population, we're being asked to live with this enormous amount of uncertainty, and it's hitting home in a really sinister way, because it's the corridor conversations. Well, where's the vaccine? You know, isn't this a plot by so and so to the banks and this and that? And it's just, there's so much misinformation, and throughout it all, the medical professionals, we're expected to give the answers, which is happening all the time, and I'm sure it's happened to James and Matteo as well. Hey, you know about this, but we just don't have the answers yet. We just don't. And therefore, we're existing in this constant state of uncertainty, and that is really, really hard for humans to deal with. Now, I've got much more positive things to say about our situation, you know, in Geelong, I suppose, but I just want to acknowledge this kind of this roller coaster, this sort of gathering fear that everybody's got without evidence. We're existing with tiny bits of evidence that will come. The epidemiologists and people like James, you know, will map this thing, and we will know more. But at the moment, we really don't know. All we've got is a horror show in New York or in Milan or in, you know, Sydney potentially, or London, the south of England, as James says. But really, we don't know. And it's very, very hard to exist in that state for an extended period of time.
Yep. James, can you give us some certainty, mate, with your research?
Yeah, what's the answer? When's that vaccine coming out, James?
Yeah, come on,
hold your breath.
One thing I wanted to ask you about is, do you know anything around that? Like, obviously, my wife's a doctor, and there's a lot of anxiety now, particularly because of what's being put out there around the rate of healthcare workers that seem to be getting quite sick. Is that from just more exposure, or is there something else with this virus?
I'm not really sure. I mean, the virus is really, really easily transmissible. So, you know, it just seems to explode. You know, it's very hardy. It kind of seems like it survives on surfaces for ages. So, and there's you know, we're not really 100% sure. Is it like the actual mode of transmission? There's some questions as to whether or not the PPE is appropriate, and I think the PPE that we're being told to use, I think it is appropriate given what we know. Are healthcare workers at more risk of severe disease? Was that your question, I guess? I guess
Yeah, I think it's more there's if you're a healthcare worker and you're exposed to more patients, is there obviously more chance of contracting COVID, and it seems like there's a lot more that are having serious side effects rather than having just minor symptoms and getting over it quickly.
Well, I guess it's quite anecdotal. I don't think anyone's done the numbers, but as healthcare workers are always more at risk of being exposed to these things. So that's gonna bias the data, because you're going to see lots of healthcare workers exposed. That's just going to happen because you're dealing with patients that are sick. I mean, there may be a dose effect. So if you're dealing with someone who's very unwell and they're needing intubated, or they're getting some aerosol generating procedure, you might get a higher dose than you might get from normal transmission. But I don't think there's been any clear signal for that at the moment. I think we all know. I think we know now that the strongest risk factor for a poor outcome is age. And I get a bit anxious about when people say, "Okay, we're going to get all these retired doctors and get them back in the front line." That makes me a little bit anxious. Do we need to be doing that? But as far as healthcare workers experiencing more severe disease, I don't think there's any data on that. I think we're just going to have to come back, like Chris said, and say, I don't know.
Yeah.
I think I can speak to the process. There's a lot of and this is I think this is one of those situations where people are, you say yourself, when we spoke the other day, as soon as a couple of doctors, or a doctor and a physio or a nurse, get talking, there's a language that seems impenetrable, a way of communicating. And I think people are, not even people that we think of as having poor health literacy, but just, well-educated people are scrambling to become educated in quite complex things, really. I mean, if you're talking about epidemiology, virology, the human immune system, patterns of transmission, how to intubate, what does intensive care mean? I imagine that most people hear life support machine and kind of think of that scene in Aeroplane with the beepy, the beeping machine or whatever it was. These are complex issues that people are kind of struggling to learn. And I wanted to reassure, I suppose, not reassure, but I wanted to speak to the efforts that are being made by certainly my college, the Australian College for Emergency Medicine, and I'm sure other colleges, to really put, to use this calm before the storm that we have at the moment, to really get in place all of the processes that we need. I'm talking about minutiae. I was just looking at the college website that's especially for COVID, how to ventilate, how to set the machine up that breathes for you, the life support machine, the best way to do it. This is the sort of pressures we want to be setting. This is the volumes, and this is the sort of ventilation. These are really specific things that, I feel for my brothers and sisters in Italy so much, because it feels like you guys were just, overwhelmed with this thing before you had the chance to really put these things in places. Whereas here in Australia, we're doing all we can to mitigate that sort of being taken by surprise by this thing. So, for example, somebody came into my emergency department yesterday with, on a ventilator, on a life support machine, for a completely unrelated issue. Nothing to do with COVID. But because we had to change him from the ambulance ventilator, life support machine, to ours, the whole of the resus room was covered in plastic. Everybody donned, the whole thing was done, over the top, way more care before even disconnecting the tube and reconnecting it, having turned off the ventilator. These are extreme measures that I've been a doctor for 25 something years, 6 years. I've never seen anything like this. People are pulling together, making sure everyone's okay, checking each other. You sure you know how to take this on and turn it off? I wanted to reassure, I suppose, if anyone's going to watch this in Australia, or wherever they watch it, that health professionals are really pulling together with this. This is our one, please God, once in a lifetime sort of battle.
Mm.
I want to call it a war.
I do not know if it's a good idea to ask the retired and the young doctor to go into COVID, into the
Front line.
The trenches,
Yeah.
the first line, because this has happened. That's for example, I think that they won't call me. If they call me, I will go, because personally I'm not worried. For sure, I have some fear, but I'm not worried about the
Health repercussions.
The disease. The problem is that if they call me, they put me in the emergency. So as James say, I can manage a ventilator, I can manage a CPAP, a CPAP. I can do. I just can't. My experience is in nutrition, is in heart disease, but not in acute in acute events, but just in management of the heart problem. And so as all the differable health problem can be postponed.
Mm-hmm.
Okay. So I don't think is, in my opinion, I don't think is the one that can help us. According to the situation in Italy, what I think is that it's not only health personnel that we need, but in particular several professional figures to form a real crisis unit. For example, logistic people. I don't know, engineer. I don't know if because now all is in the hand of the health minister.
Administrators.
In the health minister is not a doctor. They are not on the file. So they are just men. They try to do their best. In Italy, sometimes even if they do their best, they do shit. Anyway, but because just the doctor, not because I'm a doctor, but the doctor here are very good. But the doctor are not just the problem; it's the manager of the problem. For example, some suggestion: why don't give more responsibility to the family doctor? If the family doctor can reach all that people, can visit all that people, because they have the protection, because the authorities have a plan for that, maybe also that people, young people, or also old people that has not any other problem, can't arrive at that point that needs to go to the hospital and need to have a tube in the throat.
Okay, those of us that are specialists in critical care, let's say, we will do the critical care work. But as I forgot who said it earlier on, but somebody said that, we're still going to have people come in with kidney failure, heart attacks, broken hips, everything else. What we need, and what I think will happen, is if you're an orthopedic surgeon, you say, "Yep, forget about that. We've got it." I don't spend an hour or whatever making phone calls, ordering X-rays, trying to get somebody to see the patient with a broken hip. The orthopedic surgeon says, "Yeah, we got it," and they come in and do that. The vascular surgeon, if they've got a problem with a bleeding aneurysm, a blood vessel or something, they go, "Yep, we got it." The kidney failure, okay, the renal specialist takes care of that. So my senior colleagues, the surgeons and the physicians, who the way medicine's arranged is very very much along the lines of the registrar in Australia. The registrar, or sometimes even more junior, will kind of see the referral from emergency, and eventually, the consultant may see them. But I think what we're going to see is the consultants play a bigger part in the early management of patients that need acute care, because let's not forget all of the outpatient clinics are going to close down, or have closed down, or about to. All of the non-essential surgery is going to stop. So all of these people are still there. They still need their health care attended to. And where are they going to go? They're going to go to the GP surgery. Well, they're overwhelmed. They're going to go to the emergency department to say, "Well, you can't come here," or "You can, but we're dealing with COVID. So I think you're not going to have to bring in an endocrinologist, someone who specialises in diabetes, to start intubating a patient with COVID, but they are going to maybe look after the person who comes in with an extreme complication of diabetes.
Yeah,
that makes sense.
I think that's important. Is like keeping the day job going and getting the things that we should be doing done well. And I think, as you said, we've seen the same thing here, is that all the specialties have become much more proactive, and in as soon as someone shows up, they're on it, and the radiology department have really expanded, so their scans are just happening immediately now, and you can make decisions based on that. So that is encouraging to see here. Like, certainly, it sounds like you've had the same experiences. Everyone has just said, okay, we're going to do what we do and make sure we do it really well and really quickly, so that it takes the pressure off.
Yeah, I think that's one positive.
We're seeing these effects, disasters happening in places like Italy and that. But James, what's going to happen in these more sort of underdeveloped nations? I mean, how are they going to cope if places like Italy are struggling?
Yeah, so I mean, the healthcare in these places, like Uganda, where I was, is a relatively well-developed African nation, and it has what's thought of as quite a good healthcare infrastructure. But there's a lot of poverty there. You know, we're all in lockdown, but we find it very difficult to how lockdown would apply there. I don't think they're aware of a lot of cases there, but that might reflect a kind of disparity in testing, so they don't have the same testing ability. So yeah, I am quite worried about Africa and what happens if it gets into Africa in a big way, because I don't think they'll have the access to things like intensive care that we see here. It's effectively non-existent in comparison. There is a large young population in Africa, so the kind of population demographics are very different to what we have. So maybe they've got a bit of hope there, and that there's a lot of more young people, and hopefully that we won't see as much severe disease and mortality. But I think I would be worried about what happens in the context of a large outbreak there.
So I suppose, guys, the $1 million question is, when are we going to see a bloody vaccine? Because until we get that, I can't wrap my head around how anything's going to return to some sort of level of normality.
I've got a question actually for James. I mean, there's an old-fashioned way of treating things, which is to give the serum of recovered people to sick patients. I believe it was used in a Spanish flu outbreak 100 years ago and some. So what that means is you take the blood cells out of the blood that people donate all the time, which they need to do, by the way. That's an important message. They need to keep donating blood during all this. And then if you've recovered from this, and obviously there's mutations, and James will be able to talk about that, but if you've recovered from it, then you've got antibodies within that serum that can then be used acutely to treat people. It's an ancient way of treating people with infectious disease, but maybe it's faster than I've heard 12 months, 18 months maybe for a vaccine.
Yeah, so I guess there's two things that we really need. We need good treatments, and we need a vaccine. So convalescent plasma, like you said, is actually currently being evaluated in a few clinical trials, mainly in America. There's a lot of anecdotal evidence that this worked for the 1918 influenza pandemic, and there is evidence that it works for other infectious diseases like Lassa virus and things. So there is a bit of a history to that. So that's currently being evaluated in trials. Another thing they're looking at is, within someone's plasma, what are the antibodies that are actually working on the virus? So can they identify a particular antibody that people who recover develop, and can they manufacture that antibody and use that as a therapy? There's a couple of other drugs which are in trials. So there's remdesivir, which is an antiviral which was previously used against Ebola. It wasn't that good against Ebola, but there's a signal that it might be quite good here. You might have heard about chloroquine, which again appears to be a huge amount of evidence for, but that's being evaluated in trials. And then they're also using some HIV drugs to see if they work on this. So so I think protease and HIV protease inhibitors. So those all need to be evaluated in a proper trial before we can say use them, because they might be doing more harm than good. So there are a lot of trials, and hopefully we should have some data on that soon. As far as a vaccine goes, it's very easy to make a vaccine, and there's probably about 10 vaccine candidates at the moment. The problem is, does it work? And we don't know if we're going to get a vaccine that works. That's one of the scary things here, is we might make a vaccine and it might not be very efficacious. So vaccines need to go through 3 stages to become, before we put them into practice. So kind of phase 1 clinical trials, phase 2 where you look at safety, and then phase 3 where you kind of look at it in a real world environment. And loads of groups are racing to get this out, but I can't see this happening. I can't see any, and then you have to manufacture it and deliver it to everyone. So I don't see it happening. Certainly not this year. We're probably looking at about 18 months if we get one that works.
So, okay, 18 months. Say we flatten the curve that we're all talking about now in the media, and we get to a point where cases have sort of dropped off quite substantially. But because the population, people like me that aren't medical, and all we've been fed is just fear campaign after fear campaign, and we're seeing images in the hospital and that, I think the mental health side of this is going to take a big toll, because people are going to be too scared to return to normality, because you've seen images of young people, particularly, dying from this. I want to ask you, Matteo, how's the mental health side of things in Italy at the moment? I mean, you've been in lockdown for 30 days. We're a week in already. I've said it many times. I'm so sick of watching Frozen and the kids just driving me up the wall. But the mental health side, mate, how are you going, and how are your colleagues in Italy and friends and family holding up as well?
I think that's, but if I have to speak just for myself, I have to say that in these 30 days of quarantine, I gain a lot of time for myself that since I was 25 years old, I never had. And also I'm lucky because my wife is still working, and and so for 3 hours a day, the babies go with the grandparents. So I have 3 hours of completely freedom to change my body, to change my my brain. So this is my perception. This is my feeling. For in general, speaking in general, I think that I love, Dan, I love this country because Italy, with his good thing and bad thing, is just a country that you can love. Also, if we have mafia, we have bad politics, but we have a lot of bad, very good things. So is a country that you don't love. I love this country. Yeah. And I think that the feeling of the person of all the Italians are to fight together for the same stuff, for the same goal. And from yesterday, I hope not fake, is there from yesterday night was the news that we touched the peak. So in the last 2-3 days we saw that the curve arrived at a plateau, and now we are seeing a descent of the curve. I mean, curve in contagious and in contagious. So as they told us that we reached the peak, everyone is happy because everyone was involved in this, and everyone fights together for the same goal, and that's why I think that the brain, the thought are still positive. Mm-hmm. For me, the problem is not the present, and for the mental problem. Okay, but not just the mental. All the problems, not just for the present. as is not for the immediately future, but is the distant future. How the economy will go, how the health will go, because for sure this coronavirus, has all the coronavirus will became in the autumn. Maybe I hope James can say some positive stuff, but maybe became in a little bit weaker than he is now. So the problem is my thought is for the distant future. Luckily, this country, I mean, the average people, for the average the people, just think about the present and the immediately future.
Yeah. Chris, obviously, yeah, this is going to be a big issue back home. It seems like you're a bit of a motivator among your crew. Are you going to be taking on sort of part psychologist as well, you think?
Yeah, well, I don't know what Sarah's told you, but I mean, look, I did some work for our college a few years ago on the well-being of doctors. You know, it's been and then I did another. I chaired another group for the local university to do with the well-being of the student population as well. You know, it's something that's really close to my heart. Okay, that I suppose those are my bona fides. That ironically, the answers lie in advocacy in the end, you know, at the political level, for beds, for staff, for equipment. And guess what? I don't think I'm saying anything controversial here. Certainly in the UK, where I trained in London, and in the NHS and in Australia, there's been a systematic underfunding of health services for decades now. Certainly since Margaret Thatcher got a greengrocer called Griffiths in the 1980s to take a look at the NHS, and that's where it all began. Bed closures, hospital closures, you know, the whole thing. Okay, that's all I'm going to say about politics. The well-being side of things, I think I've got to look at the positives, and you're right. You've got to, as a leader of a team, or as a senior doctor, you do have to lead from the front. And it kind of goes back to the other question about, are people going to, you know, you asked about, are people going to call in sick? You know, are they going to refuse to do work? I'd be really surprised. I think you sign up for this gig and you take this sort of stuff on. You know, whether it's getting swung at, you know, by a drunk in the emergency department on a Saturday night, or spat at, or dealing with this, you sign up for this, so you do the job. I think the positives are that the fellowship of healthcare workers, just like you saw in 9/11 with the emergency services, or post 9/11, you know, there'll be a pulling together. There's a sense of this being together. Like my brother Matteo is going through it. You know, my brother James is going through it. It doesn't matter that you're 16,000 kilometers away. You know, you're my brother, and you're going through it, and we're there with you. You know, there's this kind of sense of oneness, and I think that's a really important thing to focus on. There's already been, and this is a very UK-centric thing, but the Dunkirk spirit. You know, this sense of being in this together, and it's a desperately difficult time, but we're in it together, and the only way we can get out of it is by helping each other and caring for each other. And so I think that's a really important message. On a personal note, the last time I was in Italy was in September with my wife and 3 kids, and at that time we went to Rome and to Florence and out to Tuscany, and it was just, as always, is wonderful. And the place we stayed in Rome, beautiful little, just a really simple little beautiful hotel. We emailed my wife today to say, we're really struggling, we're going to close. Would you perhaps maybe book a night, or book some time for a year in credit, so we can keep going? And we said, yeah, we're going to do that. We're going to book. We're going to give them some money to say, we're going to come and stay with you when this is done. You know, because God knows we need Italy, you know, God knows we need Rome, and God knows we need Florence, and we need all of these wonderful places around the world that we love to travel to. So, Matteo, we're with you.
Thank you.
Agreed.
James, you were talking before that it could be sort of 12 to 18 months. So, what do you think the predictions are saying, or estimates on just how many people are going to be infected by this? Even if they do take the social distancing and all these sort of things, because for someone, as I said, it's not medical. Like, all I'm seeing is the numbers going up and up and up, and if everyone's staying at home, you can't really sort of wrap your head around why that's sort of happening. And if it does flatten, what are going to be the non-negotiable rules that will have to be enforced until there is a vaccine, or how's all that going to work?
It's a really difficult question. It depends. I mean, it's going to be different everywhere in the world. Every government's going to kind of attack this differently. The problem is we're so interconnected, as we've seen in the UK. Like most of the cases in the UK, obviously all the cases in the UK have come from abroad. So if there's an outbreak in one part of the world, life in the rest of the world isn't really going to be normal, even if everyone else eradicates it. So it's going to be very tough. I think the thing is, the numbers are going up just now, but what you're seeing is people who were infected kind of 10 days to 2 weeks ago. So you won't see any impact of lockdowns or anything for a few weeks to months after they do it. But it is going to be very interesting to see what they do after this, because they can't keep everyone locked up forever. So if they slowly release us and reduce the lockdown, but that will have to be combined with a very aggressive kind of epidemiology type response where they test people aggressively. You isolate people who are waiting for a test, or you isolate people who are positive. I think a model like that, which they kind of employed in South Korea, you can kind of have a degree of normality with ongoing infection as long as people comply with that. But if I'm honest, I'm not sure how it's going to pan out. And I think a lot of the modelers and the people who make these predictions and models, they're not really sure. So in the UK, a lot of our modeling was based on a model which the guys that did it reevaluated it as the data came out, and they realized that the initial model had not got it wrong, but it was inaccurate. And as such, they adjusted the model, and that's what saw us change the way we were responding to the epidemic. So I think you need to remember, when you see these models, kind of I heard a good quote, that all models are wrong, but some of them are useful. So all models are wrong, some are useful. So just bear that in mind when you see these predictions.
Now, guys, obviously, you're all busy, living busy lives, and I appreciate you taking the time. I want to give you a chance to each sort of sign off. Matteo, as I said, mate, we're all thinking of you over there and thinking of the Italian people. What message do you want to finish on, mate, for everyone that's tuning in and listening?
Well, in Italy, we always say "ce la faremo." It's like we will do that together, and stay at home. Yeah. This is a slide message.
James,
it's very important.
James, what do you want to finish for people in terms of a couple of key things to remember when they finish watching or listening to the podcast?
I guess listen to the people in charge, because they are doing the best they can do in a pretty difficult situation. So follow their advice, and if that advice is stay at home, stay at home.
Yep. And Chris, I've got a feeling that you're going to finish this on a positive note, mate, because we definitely need something.
Okay.
What do you want to wrap the show with, mate?
Two things to say. One, the healthcare professionals have got your backs, really. I want to just reassure people that we've got your backs. We you can trust us. And two, I'm going to plagiarize Muhammad Ali. Me, we. There you go.
Yeah.
Fantastic. I can't thank you guys enough. Obviously, it's a pretty stressful period, and there's a lot of hard work going on all departments. But really appreciate you guys taking the time, and there's a lot of valuable information there. Because, as I said, I thought if you drank hot water, wash your hands, and steer clear of your neighbours, you'd be bonza. So there's a lot more to it than that. And hopefully, things are on the up, and as you said, just got to stay positive. But you know, as
Thanks
I said,
for
really
organising this,
appreciate
Dan.
it.
Dan, really, mate, thank you for organising this. It's a really great thing you're doing. I really appreciate being invited to do this. Thank you.
Yeah.
Great.
My pleasure. Stay safe, everyone, and we'll speak again soon, eh?
Lovely to meet you.
Cheers, boys.
Thanks.